Swayam Prabha. Digital India. Educated India.
Welcome. Today's session is on IGA nephropathy. So, we will have a look into the different aspects of the pathology of IGA nephropathy, the clinical features, the lab findings, etc. And before that, we will look at a case which has been diagnosed as IGA nephropathy. So, 42-year-old male who was recently diagnosed as being hypertensive presents with reduced urine output for the last 2 days. He gives history of repeated episodes of eye colored urine for the past 1 year and has bilateral pitting pedal edema. Urine examination detected 3 plus protein, numerous RBCs per hypa field, pus cells of 6 to 8 per hypa field, and serum urea creatinine were elevated. Total protein was 5.1 grams per deciliter, C3 was 42 milligrams per deciliter, and ESR was 92 centimeters in an hour. The biopsy of the same done showed diffuse proliferative glomerulonephritis with 40% crescents, and immunofluorescence depicted IgA dominant deposits, especially in the mesangium, with focal segmental glomerular capillary wall deposits. C3 was 2 plus along with IgG, and it was lambda dominant over kappa. IgM and C1q as well as fibrinogen were negative. So, this was diagnosed to be a case of IgAN. So, what exactly is IgAN? So, we will study the etiology and pathogenesis of this disease. So, we will have a look at the renal morphology under the headings of light microscopy, the immunofluorescence picture as well as electron microscopy. Then we will see the clinical features including the laboratory diagnosis of IgA nephropathy and the progression of this disease as well as the complications associated with the case of IgA nephropathy. So, what is IgA nephropathy? It is also known as Buerger's disease. Now, this is characterized by prominent IgA deposits in the mesangium on immunofluorescence, and it is a frequent cause of recurrent hematuria in patients. Now, most common glomerulonephritis worldwide is thought to be IgA nephropathy. It overlaps in children especially with a condition known as Henoch-Schönlein purpura, and secondary IgA nephropathy is also been detected in patients with liver diseases as well as with intestinal disease. In liver diseases, it is because of catabolism of polymeric forms of IgA usually occurs in the liver, and in these cases it is reduced. In intestinal disease, there are mucosal abnormalities which may give rise to this IgA nephropathy. It is just theory right now, and it has not been definitely proved. Etiologically, MHC2 is held responsible for this condition along with the predisposition to the disease developing following exposure to certain kinds of bacteria or particular antigens in food as well as viruses. So, the pathogenesis behind development of this disease is most importantly aberrant glycosylation of IgA, which is deposited in the glomerular mesangium along with its antibody, and activation of the alternate complement pathway. So, it is a multi-hit etiology. Normally, IgA is in monomeric form in plasma, and the polymeric forms are catabolized by the liver. Now, in IgA nephropathy, polymeric IgA is seen in the plasma, but this alone does not account for the disease. So, what exactly happens? Familial susceptibility to this disease is HLA linked and may be associated with certain loci on MHC2. And environmental studies as well as epidemiological studies have shown that the susceptibility to disease may also be in some individuals linked to altered response to certain viruses, bacteria or certain antigens in food. So, What happens in these individuals is that there is a hereditary or acquired defect which causes abnormal binding of your galactose linked sugar called as O-linked glycan to a specific region in IgA, specifically IgA1, and this in turn gives rise to an abnormally glycosylated IgA. The most important culprit in development of IgA nephropathy is this abnormally glycosylated IgA. Abnormally glycosylated IgA goes into the glomerulus and specifically deposits in the mesangium. Meanwhile, circulating abnormally glycosylated IgA polymers elicit an immune response, and therefore, autoantibodies will bind to it. This circulating immune complex is then deposited in the mesangium. Meanwhile, the antigen which has been deposited there earlier on, that is this abnormally glycosylated IgA, causes immune complex deposition there. So, in the mesangium an immune complex is formed, or a circulating immune complex can also be deposited. Now, both of these give rise to expansion of the mesangium. So, we will see how the mesangium is expanded. This is how it is normally, and this is how it is in IgA nephropathy. So, it stimulates the mesangial cells to proliferate, and they get activated and secrete growth factors, cytokines, as well as extracellular matrix, and that is why there is mesangial expansion and mesangial hypercellularity. Now, these in turn activate the alternate complement pathway, that is C3 levels are increased here, and C3 will be deposited there. The activated mesangial cells and endothelial cells will secrete certain cytokines, and these bring the WBCs to that location. So, the activated WBCs will be involved in inflammation as well as repair, wherein they may remove some of these immune complexes. Under the light microscopy, the glomerular lesions are found to be variable, that is all glomeruli are not affected similarly. Different kinds of lesions can be seen in the glomeruli. Now, the glomeruli can be normal, or they can progress to mesangial-proliferative glomerulonephritis, which means proliferation in the mesangial region of the glomerulus. Now, if more than 50% of the glomeruli in a particular biopsy are involved, then we call it as diffuse, as depicted in this picture. So, more than 50% of the glomeruli are involved, it is diffuse. Less than 50% of the glomeruli or up to 50% of the glomeruli are involved, it is focal. So, we call it as diffuse proliferative or diffuse mesangial-proliferative glomerulonephritis, or focal proliferative or focal mesangial-proliferative glomerulonephritis. Then, in each glomerulus, if the entire glomerulus is involved, then it is called as global, whereas if less than 50% of the glomerulus is involved, it is called as segmental. The cellularity in the affected glomeruli is variable, and it involves the mesangial cells, the endothelial cells, as well as WBCs. Rarely you can get the epithelial cell proliferation within the Bowman's space. So, whenever the areas of inflammation heal within the glomerulus, it gives rise to segmental sclerosis. So, depending on these, we have immunofluorescence pattern also. So, on immunofluorescence, the predominant pattern is deposition of IgA, most important, in the mesangial region. So, it is the dominant pattern. So, IgA dominant along with C3. So, if IgA and C3 are present to the similar extent, then it is known as codominant. It is mostly seen in the mesangium, but rarely it can affect the capillary walls also. IgG may sometimes be seen as also IgM, but C1q, that is a classical pathway, is negative. Usually amongst kappa and lambda, it is lambda dominant, and rarely properdine can also be seen. Electron microscopy depicts mesangial deposits predominantly, and rarely a few deposits can be seen in the subendothelial space. So, this is a special stain, that is periodic acid shift stain, PAS stain, depicting expansion of the mesangium as well as increased number of mesangial cells. We call mesangial hypercellularity whenever the mesangial space is occupied by more than 3 mesangial cells. The endothelial capillaries meanwhile look normal here. the slight endothelial proliferation in this aspect, the tubules etc. appear normal, as well as the Bowman's space here, there is no epithelial proliferation. Now, this is immunofluorescence depicting the same pattern, that is in the mesangium you are seeing immunofluorescence deposits. This is an IGA picture. Now, we use the modified Oxford classification system to prognosticate such patients, and this is the MEST-C criteria is what is followed right now. Earlier different classification systems were there, so which gave rise to a lot of confusions on the clinical aspect of these patients of IGA nephropathy. So, now universally MEST-C has been recognized as an important classification system. Adequate prediction of clinical outcome and risk to progression as well as prognosis is depicted with this MEST-C criteria, especially they say as of now they say the T aspect is more indicative. Okay, from the microscopy, let us move on to the laboratory findings in this. Now, the laboratory findings depend on the presentation of the patient, whether it is just with hematuria or proteinuria. Hematuria is seen in most of the patients. It could be microscopic or macrohematuria. Microscopic hematuria we say whenever there are at the most 3 your RBCs per HiPA field under the microscope in at least 2 to 3 your samples of urine. Proteinuria could be mild, moderate or severe, but usually it is mild. Azotemia, that is elevation of blood urea nitrogen, is seen in patients who progress faster to renal failure, that is acute renal failure. And nephritic syndrome is another presentation. Now, besides that, rarely other presentations include rapidly progressive glomerulonephritis, then nephrotic syndrome, etc. Acute renal failure is very rare, as well as chronic kidney disease. Now, chronic kidney disease is how most of these patients progress, but the presentation as chronic renal failure or chronic kidney disease is rare. So, in the urine what do we see? So, in urine protein is usually negative, but can be present, but blood is most often present. As I said, it could be microhematuria or macrohematuria. The other aspects, that is urobilinogen, ketone bodies, bilirubin, nitrite etc. are not seen. Under the microscope, RBCs are normally present in these patients. The dysmorphic RBCs are more often seen, and this is because it is a case of glomerulonephritis. Pus cells, that is your WBCs will be seen, and epithelial cells may also be present. Casts are WBC casts or granular casts. Creatinine levels are usually normal or may be elevated depending on whether the patient has got nephritic syndrome as well as progression to rapidly progressive glomerulonephritis or acute renal failure. Urea also is usually normal, but may be elevated. Lipid profile is normal unless the patient progresses to nephrotic syndrome. C3 levels are normal, can sometimes be reduced. Now, when it is reduced, it says that the patient is progressing to more severe renal disease. C4 levels are normal, and elevation of C4 levels are also found to be associated with progression to severe renal disease. Proteins are usually normal, but may be reduced also. Albumin and globulin will be reduced if proteins are reduced. Clinically, it usually affects older children and young adults. Then presentation is as hematuria, which is episodic or persistent. Only hematuria is seen in 30 to 40% of the patients, and this follows a particular infection, maybe respiratory tract infection or involving the gastrointestinal tract or the genitourinary tract. Then this microhematuria is in episodes, meaning it subsides and then recurs, subsides and then recurs. So, episodic hematuria is typical. Gross hematuria, if seen, is usually in younger patients, whereas microhematuria is in older individuals. Sometimes it can be hematuria along with mild proteinuria, and rarely as an acute nephritic syndrome or acute renal failure in 5 to 10% of the patients. Very rare or occasionally it can be as nephrotic syndrome, and most of these patients can progress to chronic kidney disease, or it could be a presentation as chronic kidney disease when the earlier symptoms have been very mild. So, that can be an insidious onset of chronic kidney disease. So, how do these patients progress? So, rarely they can progress to rapidly progressive glomerulonephritis or acute renal failure, especially in children who present with gross hematuria, hypertension and azotemia. Nephrotic syndrome is seen only in 5% of the patient, and chronic kidney disease progression to that is in 15 to 40% of individuals with IGA nephropathy. The progression when it occurs is usually very slow. So, some of these patients will develop chronic kidney disease, and an increased risk of progression to chronic renal failure or chronic kidney disease is seen in association with an onset in older individuals, heavy proteinuria, hypertension at presentation and the extent of glomulosclerosis on biopsy. Now, IGA nephropathy can occur in transplanted kidneys also to an extent of 15% of cases. So, this recurrence is deleterious to the transplanted kidney. So, with this we come to the conclusion of this session on IGA nephropathy. So, it is one of the most common glomerulonephritis. Presentation is as hematuria or as nephritic syndrome. It is associated with 3 factors, that is aberrant glycosylation of IgA in the mesangium leading to mesangial deposits of IgA on immunofluorescence and activation of the alternate complement pathway. Histopathologically, we will see mesangioproliferative glomerulonephritis with IgA and C3 either codominant or IgA dominant deposits on immunofluorescence and mesangial deposit predominance on electron microscopy. The revised Oxford MESC classification is important for predicting the outcome as well as prognosis in these patients. That is it for today. Thank you so much for your kind attention. Thank you.